Good afternoon, everyone, and welcome to our session on mealtime support. Hopefully, we've timed this session well, that we've all realised the amount of support that we would have needed to quickly gobble down our lunch between really interesting sessions. We have two speakers today. One of our speakers, Susan Guthrie, is going to appear by a video to present her findings. And then we also have Sally Morgan as well. So Dr. Susan Guthrie is a Principal SLT and a Cardinal Clinical Academic Research Fellow at Leeds and York Partnership Trust and at the University of Leeds. Sally Morgan is a senior lecturer in speech and language therapy and a clinical doctoral research fellow at City St George's. So we're going to start with some housekeeping. If we can pull up the housekeeping slide, thank you. So I think you will all be used to this by now. We do have a questions tab, so please feel free. We have a Q&A session at the end to input your questions into that. Also to upvote them if you think it's covered the topic that you would like to be asked as well. There is a chat tab as well for any comments, feedback, information sharing whilst we're going along, and a feedback tab as well, which helps us to understand how good the session was and how we can improve it in the future. We would ask that all questions and any chats are respectful, that they're kind. These are monitored for their content. If you're having any technical problems, please see on the left-hand side of your screen, there's a help desk icon. If you click on that, you'll get tech support there. And please stay with us right to the very end, where you will get your code to be able to earn more of those points, because points mean prizes, within the conference as a whole, as will adding comments and sharing questions. So firstly, we're going to be looking at the work that Susan has been doing, and we're going to share the video of her work.
Hello, thank you for accepting this presentation. My apologies for not speaking live today, but I have to attend another conference in person today. I'd like to acknowledge the support from the QI team and my PhD supervisors, but my huge and grateful thanks to the patients and staff who have all worked on this project to support Feel Good Mealtimes across Leeds and York. This is the key question and the starting point for my research and subsequent QI project. We asked, how was your meal? Did you enjoy it? And think about the lunch you've just had. Did you enjoy your conversation or a nice quiet moment of respite? What is the impact of food and drink on your mental well-being? Is it positive? Anxiety provoking? How does it make you feel? This research had full HRA ethical approval and was supported by the Leeds and York Partnership Trust and the University of Leeds. So this is what patients and staff have told me. But interestingly, they've also reported it's very much a forgotten topic. It's not discussed in the everyday world. It's not considered in a high-pressure environment that is an inpatient mental health ward. And the patients we work with who are admitted for a mental health recovery are struggling very often with the experience of mealtimes in this crowded, noisy and institutional dining room. And we were interested to explore how this affects, possibly deteriorates their mental well-being and other consequences for their physical well-being. What would be the impact on nutrition and meal safety if mealtimes aren't going well? We looked at how mealtime pressures and levels of anxiety contribute to pacing and cramming and the impact that has on swallowing safety. Leeds and York offered the opportunity to link with the QI team and brought this structure and support for the investigation of how to implement PhD findings. We were delighted to have an opportunity to demonstrate that research can be relevant and grounded in clinical concerns. The 6-step process here is based on the DMAIC, which is an evidence-based methodology used in Six Sigma and the Lean Six Sigma to improve the processes. This model for improvement is a simplified translation of these methodologies, and it's specifically designed for use in healthcare. It was really helpful to have this structure as we moved through the process. So step 1 is to identify what the topic is all about, what the issues are. And this is based primarily on the PhD study interviews. We talked as patients, staff and speech therapists to understand the different perspectives on mealtimes. By discussing both home and ward mealtimes, the positives and the negatives, we started to understand a bit more about the variation and the influences present. How does it feel to be in the ward dining room? Can you describe your experience? Do you have any experiences of swallowing difficulties or choking? What's it like to be in that room on that day at that time? And how does it vary across the week or across the day? So the interviews were transcribed and then analysed using reflexive thematic analysis following the Brown and Clark model. And we captured all the patient stories to understand the level of interest and need. We disseminated these in a video, which hopefully we'll show in a moment, and this has also been accepted for publication. The themes are shown here, but the central, the most overarching theme was the impact of the heightened emotions at mealtimes, and that came across very strongly from all the interviews. Patients, staff and speech and language therapists all had the same report. It's a very stressful, highly emotional environment, and the sub-themes are listed here. So we wanted to take these themes back to the wards and understand what was relevant in this particular setting. You see some pictures of the inpatient dining rooms, institutional, quite clinical, very few sort of soft furnishings, very little on the walls. Not a very comfortable environment, I think you'd agree. So step 2 of the QI process is to determine what measures would be relevant. We looked at all sorts of options, but we came down to this workable set, which we felt would highlight the issues that were present. And we wanted to understand what the mealtime was doing for mental well-being and how that then impacted on both physical and mental well-being. But time and again, this was the impression that we were getting from staff and from patients. The mealtimes is just one of those things that has to be got through. It was a task focus, essentially. So we observed lunchtime and evening meal, tea. We hoped to have discussions with staff and patients as they left the room after each meal, but that wasn't really feasible. People dashed out when the meal was finished. So instead we offered focus groups and discussion meetings. There was the Your Views meetings ready for us to go and contribute to. And it was really interesting to hear the people's insights and comments outside the dining room. And I have to say that the information we got from this very much related closely to the PhD and the interview findings I had at that stage. So I wanted to show you the format for our observations. We used this map or figure to show where the hatch was, the servery for the food. There was one window, one door, and then these 4 tables. The 5th table was very much given over to staff admin. Staff sat there with a pile of menus doing the paperwork as people were eating. Very few people wanted to sit at the window table. That was hardly ever used, we noticed. And here's an example of a completed form. We used this format to give us an idea of how long people were lingering after the meal. We wanted to know if people stayed after they'd finished eating. Did they stay to chat or show another positive response to being in the room? And using a tally, we counted, you can see in a moment, how many conversations actually happened. We found that the majority of conversations were task related, things like asking to see the menu that they'd ordered, asking for a sauce to be passed. Interactions were typically very short, and it was rare to see longer, more informal chats, either between the patients or patients to staff. You can see there that the time spent at meals was varied. And again, as we watched, the mealtime felt very task-focused. We didn't capture on this how many people either attended the meal briefly and then left. So there are a certain number of people would put their head round the door, see that it was busy and then not come in. or they'd come in, grab something very quickly and disappear straight away. So this is only the time spent for people sitting down with a plateful in front of them. And there was considerable variation. I've put this slide in, but really it doesn't capture the variety in that some mealtimes were entirely silent. Others had one or two patients present who were more keen to interact. So this really doesn't show the wide variation, but it does capture a total of 95 conversations, which spread out over 8 mealtimes, and that could be some mealtimes were silent, some mealtimes were more chatty. So we asked the staff and we asked the patients, separate meetings and combined meetings, what could we do to improve things? And I was delighted to see how much engagement and enthusiasm there was in these conversations. We watched the video of the patient stories, and that prompted a lot of reflection from patients and from the staff. But to support that, we also offered a worksheet so that we could help record the ideas that people came up with, really focus on their insights and comments. And using the choices framework was really helpful. We could make sure that each aspect was considered. So this is a video that we used to capture the voices of the patients telling us about the mealtimes on inpatient wards. This was all working age adults. We'd like you to listen to what people told us. So we continued to collect ideas from the staff. They listened to the video, they filled out the worksheets, but there was so much rapid turnover that we find we are still collecting ideas, comments and insights. We found the choices framework is really helpful just to ground us back at individual differences and preferences. We understand the importance of customs and choices and the differences, but for us the most difficult thing as a large hospital is how we can maintain flexibility and respond to people, different times, different days, different feelings, different wishes. But we do feel this has allowed us to open up a discussion and raise the value of mealtimes across the staff and patients' level of awareness, and how much it can support mental well-being. Very much still a work in progress, but we were delighted that the dietitians and occupational therapists around us have been joining in with this. And there's definitely something about sharing food and helping others at mealtimes brings such a powerful boost for self-esteem and well-being that that's something we're continuing to look at. And this was just an example of one little thing that one member of staff had taken on herself to do. Even though she's very busy and very overstretched at the moment, she had found time just to put this table display together, and she was delighted to show us what she'd done. So that enthusiasm was very, very much acknowledged. So to summarise the barriers and enablers that we are working with, I think most people fully understood the constraints of being in a large hospital, the financial constraints, the catering setup. And it has to be said that some patients were very pleased to have, to be in a place where food was prepared for them, it was served. They hadn't had that worry or that chore to be coping with at a time when they were mentally very unwell. But it has to be said, after weeks and months, these same menus can become repetitive and restrictive. Choosing and ordering your choices is very difficult and often very frustrating when what you've ordered doesn't actually arrive. And I do think that speech and language therapists have to acknowledge the positives and the negatives around this. When we're offering assessment and advice, we need to fully understand the perspective of the patients that we're considering, understand the staff restrictions and pressures. And we do find that making time for conversations about what mealtimes are like at home are crucial in terms of how we can support and follow the person's level of need. I think it has to be said that there was the enablers included the staff who are highly enthusiastic for this. We are considering using volunteers to help out as well. And it's great to see that the wider MDT are keen to come and join in with the mealtime. People from the sort of visiting side of the team will come and join in with the mealtime. But the barriers have to be acknowledged, and staff turnover is still a concern. So it does remain a work in progress. Having this structure has been really helpful. It's been great to have the choices framework to give us a sense of where we need to focus our attention. The interim observations are positive, but we need to do more post measures. And I think it's also as an exercise of demonstrating how research can be combined into practice. It's been really enjoyable, and it's helped everyone from the senior managers to staff on the ground understand that clinicians' research can be valuable and relevant, not just an ivory tower academic exercise. And to finish off, I was delighted to get this email from a support worker who sent this email saying, just to let you know, I did the tea and coffee thing before lunch today. It was very popular. A lot of patients and staff came. Everyone sat around talking and laughing. It was really nice. And one person even came and chatted and was laughing relaxed. And even better than that, he sat in the dining room after and ate his food. He's not eaten food in the dining room for weeks. I'm hoping it's not just a coincidence. So helping patients set foot in the dining room was a big step forward, understanding what made people feel comfortable and welcome, and tried to reduce the level of anxiety that patients were feeling. So this choices approach helped us bring the focus back onto personalised care planning, to understand what mealtimes might mean for someone, what it was like for them before they were admitted, how the mealtimes helped or hindered them at home, what it's like for them on the ward having a meal, and is there some way we can use that to support people's well-being after discharge? Is having a nice cup of tea or a meal with family or a meal with a mate going to be a way of maintaining mental well-being after they've left the hospital? We would be delighted to have any comments or feedback on this. It's been very much a joint project working with the multidisciplinary team and with the QI team. I've put there the option to post questions and answers on our mental health forum as part of the college professional network, or you're welcome to email me for more information. Thank you.
That's great. I think it's really powerful as we move away from seeing things as purely a physiological dysphagia to encompassing what is eating, drinking, and swallowing. What role does it play in our lives? I think that's really powerful, the work that Susan has done. Next, we're going to move on to Sally. Sally is with us today and has done some amazing work and has looked at what the clinical practice of speech and language therapists who work with school-age children with neurodisability and/or pharyngeal dysphagia who require mealtime assistance. So she's looked at a UK survey on that. So I'll hand over to you now, Sally.
Thank you. Sorry. Hi. So thank you very much for the opportunity to speak to you today. I'm Sally Morgan. I'm a speech and language therapist and an honorary SLT at NELF, North East London Foundation Trust. And this is part of my PhD studies funded by Bart's Charity and based at City St George's. You can see there the list of my lovely supervisors. So I want you to picture school-age children eating a meal. And these are the kind of school-age children that my PhD is focusing on. So they're school-age children who've got neurodisability, so an impairment with their nerves or their brain that causes difficulties and differences in the way that they move and learn. You can see that these children also have dysphagia linked to their neurodisabilities. They have difficulties biting and chewing and swallowing. And the children I've focused on also have carer mealtime assistance. So from adult learning disability literature, we know that if you have assistance or you're dependent on someone else for your meal times, you're much more likely to have a hospital admission or have a chest infection. And so that's why that's the group that I've been focusing on. You can see carers here, some school carers and a family carer, I think, in the front picture, who are supporting a child, giving mealtime assistance. And you can see that the carers are changing a lot of things within the mealtime. So there's different seating equipment here. We can see an AAC device, so different communication styles. You can also see different utensils, so a cut-out cup, a maroon spoon, changes in texture, and also even physical support on the right-hand side. So lots of changes that we ask carers to make when they're supporting at mealtime. So what do speech and language therapists do about meal times? Well, definitely, I think this is what we do. We go and observe and we assess. We observe a meal time rather than just a swallow. And then we agree recommendations with the carers. And we ask them to change things in the meal time. And basically, we're asking them to change their behaviour, change their habits. So, and the aim of that is that we'll get safe, efficient and enjoyable meal times. So safe, they're not having a chest infection due to aspiration or the child's not choking on food. Efficient, they're not spending hours and hours and hours on meals in their day, but they are getting enough nutrition and hydration, and enjoyable for the child and enjoyable for the carer. But as you may realise, it's not as easy as it may seem, and that's the acronym for my PhD study. So in my PhD, I've been looking at various different things about mealtime recommendations. The first is, what are the mealtime recommendations we should make? What carer behaviours should we change? Should it be texture? Should it be food or drink texture? Should it be the position? Should it be the pace of the meal? Many, many different things. And the Feeds Toolkit has recently come out, which is highlighting all those, they kind of call them mealtime interventions. I've also looked at why following recommendations are easy or difficult for family carers, what enables them to make a change and what are the barriers to making a change. And then finally thought about what strategies can help carers to follow recommendations. I've used theories in the back behind here, hiding. So the theoretical domains framework looks at enablers and barriers to change, and the behaviour change technique taxonomy has 93 different strategies, different ways that we can help carers change their behaviour, make it stick. So my study looks almost a bit like evidence-based practice. So I have a systematic literature review looking at what's the research evidence so far. I've got a survey of practice looking at clinical consensus, and I've done a study visiting families at home, videoing mealtimes and reflecting on those. So, and looking at family carer values. And then I've drawn that all together, all that learning, into a co-designed prototype resource, the idea of a resource. I haven't made the resource, just the idea of a resource. So today I'm talking about my survey. It's actually under review at the moment with a journal, so I'd appreciate some slides not being shared on social media today. I'm in the final term of a 5-year PhD. So I'm talking about my survey and what did I do? So this was a survey looking at therapists who are working with school-aged children. 36 questions, it's a long survey. They were multiple choice, Likert scales, sort of range scales, and also free text options. There was also an option to upload documents of how what speech therapists used in their practice. It was open in the summer of 2021. This is when pandemic restrictions were still going on. So think like bubbles in school. So who took part? Thank you very, very much if you're listening and you are one of those many people who took part or who shared the survey on social media to help the joining in. I started with 139 participants and down to 102 by the end of the survey. That's quite normal, and it was a long survey. I got really varied regions, so all the nations and all the hubs were included, which is great. Different bands, but over 50% were either in band 7 or band 8, maybe reflecting this being seen as a specialism, but a good range of clinical experience. So a very even split about whether people were 1 to 5 years or 16 plus years of experience. Very limited SLT participant diversity, mainly white women like me, but also people who said they weren't disabled. Less diversity than there is in the general speech therapy population, both in gender and ethnicity. So where are they working? What are these speech therapists doing? So the main employer you can see on the left is the NHS, but I did get people who were employed in schools or in charities or in independent work. People worked in lots of different settings. Some were based in acute hospitals, a quarter of them based in acute, but 87% working in schools and a bit less in home. In the bottom, you can see the clinical time spent on dysphagia on their weekly caseload was really evenly split. Some were only 1 to 19% of their time, and others 80 to 100% of the time, so really varied. The ages people worked with, everybody worked with school-age children. They had to be eligible for the study, but 90% were also working with preschoolers and 65% with infants, 24% with adults. So people are working a lot of age ranges and a lot of settings. It's a lot of variety to handle. And then thinking more about variety of what we're working in, if we look at the causes of dysphagia through neurodisability, people are working in all these different areas. So children with child onset disabilities like cerebral palsy or a neurodevelopmental delay or another condition like chromosomal difference like Down syndrome, but also working with children with acquired neurological conditions or degenerative conditions. People also said, about 70%, so they were working with children with autism, autistic children who had dysphagia, who had eating, drinking and swallowing difficulties. Interestingly, though, when we look at the non-neurodisability dysphagia causes, the lowest number was working in RFID, so people not working in avoidant restrictive food intake disorder, even though they were working in the area of autism. So maybe only looking at the dysphagia element of the eating and drinking, of that pediatric feeding disorder, and not looking more broadly. And many people were working with children with complex medical conditions, and people were also working with children in other areas, for example, children with cleft palate or other structural difficulties. So I looked a little bit at assessment. When we look at instrumental assessment, people had access. The most common access was to a stethoscope, cervical auscultation. But videofluoroscopy was most accessible if we talked about it being on-site or via referral. So positively, 96% of people have access to videofluoroscopy if they need it. Cervical auscultation, even though it was more accessible, it was used much less commonly. So only just over half were using it often and sometimes. Videofluoroscopy was used much more frequently, 81% often and sometimes, although 63% of people talked about sometimes and only 18% of it talked about often. So whether that's because rationing of access or just because clinically that's what we think, I'm not sure. When we think about published assessments or tools, things that we can do more frequently, that we can do regularly, people often skipped the question entirely. And if they didn't skip the question, 37% of this 101 who answered it either said they just put like a not applicable or nothing. We're not using published assessments. It's really interesting. So we are sometimes using clinical observation of mealtime assessments, the J's, or a locally personally created tool, so ones that are not standardized or validated. The Dysphagia Disorder Survey, which you have to pay for an online training course, but once you've done that, then you've got the resources. Nobody reported using it. And when we look at these numbers here for any other kinds of assessments we could do, whether it's oromotor assessment or a case history report, we're talking really, really no numbers. Only one person saying they're using the therapy outcome measures. Classification systems, the EDACS, the Eating Drinking Ability classification system, 16 people. So that's only 11% if I look at all the speech therapists who were working in cerebral palsy. So it's really low. We're just not adopting these things. And things like the EDACs are free. That is really interesting, even more to me, when I look at this first question, do you share care with another speech and language therapist? So 69% of people said yes, either they were sharing care with another person in the school, like they're part-time and they're sharing care that way. People talked about being acute or being in community and sharing care that way, or with somebody who was also at a respite centre or another centre that the child went to. So it's interesting, we don't have very much clear language, and agreed language or agreed assessments that we can kind of describe children well when we're sharing that care. We also work with lots of other multidisciplinary team members, as I expected from my own clinical practice, most commonly dietitians and occupational therapists, but those working in schools were working with the school staff regularly. Clinical psychologist was extremely low compared to everything else. And the other were things like respite carers, family carers, those kind of areas, some medical professions. getting into the nitty-gritty of what we ask people to change. So I split this into two questions, one asking changes about before the meal, things like anything to prepare the child, like a social story or sensory preparation or a sensory input to kind of alert the child before the meal. Two of them, therapists, 80% of therapists said they were using often or sometimes, and five of them, 60% said often or sometimes. And then during a meal, I talked about 17 different changes that we made during a meal, and 14 of them, 80% of therapists said they were using them often or sometimes. So things like changing the pace, changing the environment, modifying drink or food consistency, changing the position of a child. The least recommended ones were calorific density, maybe because we lean more on dietitians for that, and physical support, maybe because we lean more on our physio colleagues. We're asking family carers to change a lot of different things. I hope that we're not asking them to change all 14 all at one go. I also looked at, I asked people just a very open question, how do you support parents and family carers? And I looked at this in a qualitative analysis way. I found two key themes, which were two styles of working from speech and language therapists. The smaller group were doing a style I've called collaborative creation, and there was a much larger group using informative prescription prescribers. So when I asked about recommendations, the collaborative creators started by talking about developing them. So I asked about how do you support people to do them and how do you provide them? But they started with assessment and development. So co-production of targets, listen to the concerns or areas carers would like to develop. So they started there. The prescribers didn't tend to talk about assessment other than I'll explain it. So they didn't talk about this collaborative discussion before making recommendations. They might do it, but they didn't talk about it. Then provision. The creators talked about, I write the feeding plans together and offer additional support training if needed. Whereas the prescriber style talked about, well, I give an information session explaining assessment and advice. So they're giving training and information just as much as the collaborative ones are, but it's not so clear that there's a to-fro discussion with family carers. And then support after you've given those recommendations. So the creators often talked about things like asking them to be honest if they haven't followed the recommendations and tell me why. The prescribers often talked about providing a handout or a document or leaving a contact number for any queries that may arise. There's an acknowledgement there that family carers might not be able to follow them, but it's not so clear that there's this two-way conversation. I wonder what style you think you are, or whether you use one style sometimes and another style another. When I looked at recommendation provision and I used the behaviour change techniques, we had a really strong skill base in us looking at providing information, developing skills of family carers and highlighting risk, like what's the consequence if you don't follow this advice. But we very rarely talk about any strategies of many other options. So how we support emotions, or we could support people believing that what we do will make a difference. Any structural barriers, what's actually stopping them is the prescription is never arriving, for example, or they don't have a blender, so pureeing is really hard. And we didn't talk about problem solving. When I gave people 10 options of a multiple choice, group training, where you could see more options for problem solving, peer-to-peer, or video interaction approach were much less used than providing verbal recommendations or face-to-face training. When I looked at the written resources, thank you to those that uploaded them, I got 39 what I've called MATs. So these are easy access, easy accessible documents, often with kind of in boxes with subheadings. Interestingly, there were 28 unique different templates from all these speech therapists. We don't have an agreement on the title. So this word web cloud here is, we're not sure whether to call it eating, drinking, feeding, swallowing, mealtime. And we're not sure whether to call it guidelines, advice, mat, profile, etc., etc. The format was different. Some were landscape, some were portrait, some were 1 page, some were 3 page. There were different subheadings. Some used first person language, some used third person language. The only consistency we had was 27 out of 28 used IDSI terminology. Woohoo! But everything else was very varied. I asked about the impact of COVID pandemic, not surprisingly, because of it being done in 2021. There were the negative impacts that you would expect, and people said it did affect their service, although those in acute said not so much. People in acute did highlight mask use as affecting interaction during mealtimes. But people did talk a lot about positive impacts of access to telehealth and technology, improved their own digital skills and families' digital skills, improved access to families because school-based therapists weren't at school and weren't working with school staff. They said they really got to know the families really, really so much better than they'd ever known them before. And families being at home and a consistent one person feeding or two feeding that child all the time, they actually said that things were working much better and that the children were more healthy. In terms of their plans, they said they hoped as we were going to be coming out of final lockdowns that they would use this telehealth hybrid service when children came back to school, and they really wanted to carry on with their family contact. So as key findings for me, I think we have quite varied UK services of what we offer or who we see. Shared care is really common. We haven't started using these validated published assessments. And I think that's quite different in paediatric dysphagia to maybe if you thought about speech or communication work. Speech therapists are very aware of the mealtime changes that can be made, and they use many of those frequently. But you could use the Feeds Toolkit if you want to talk about these in more detail with families. But we have a range of techniques that really work on knowledge and skills of carers, but we're not leaning on all these other potential techniques that we could use. So I've given you some reflection points. What assessments are you using at the moment? What do your mealtime maps or dysphagic guidelines look like? Did you actually carry on any practice after the COVID restrictions? And how else can you support families to follow mealtime recommendations? Do you want to move to a more collaborative approach? Thank you very much for listening. I have a QR code if you want to sign up. At the moment, I have it's too grand to call it a newsletter. I send an email out with updates on how my PhD is going. I've got references at the end if people want to see them. Thank you. I can put a link in the chat if people want to sign up on there. Thank you.
That was fascinating. Thank you so much, Sally. And I love the discussion around that collaborative approach versus the very directional kind of this is what you're being told to do. I think that's really, really interesting. So we've had some comments and questions come through in the chat. Some of them are aimed towards Susan. I will send all of them to her so she gets a chance to respond to them and then upload them onto the platform at a later date. I will try my best as well to answer those, but I do think some of the topics are applicable to your work as well, Sally. And kind of the most upvoted question was around meal times are this interactive opportunity, the opportunity to have conversations and to promote kind of well-being. But often we make these recommendations around kind of restricting, say, talking with your mouth full and things. And do you have any advice for people on how we can kind of balance that? How can we balance the communication, the conversations, the well-being with the safety?
Okay, yes. So my safe, efficient, enjoyable comes from the NICE cerebral palsy guidelines, the 0 to 25 guidelines. And it very kindly just says you need to balance safety, efficiency, and enjoyment. But it doesn't give you any idea of how you do that. Going way back to when I first dipped my toe in research and I did a master's, master's in psychology of health, master's in health psychology. I interviewed professionals, and it was really about tube feeding decision making, actually. And it was really interesting that everybody talked all about, all these other things other than safety, and then all of a sudden, it was almost like, no, 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 actually, but safety beats everything. If you play card games, it's the trump card. And I think there's something about us sometimes being health professionals, but we think physical health is the priority, whereas actually a quality of life and mental health and well-being can be the priority. I'd really lean on some of the really lovely stuff coming out of some other colleagues. So all the shared decision making models, and oh, I'm now, my brain is fading, sorry. So Sonia Jacobs and her team at Tower Hamlets, she did a lovely presentation at the Pediatric Dysphagia Sen talking about the zone of, there you go, it comes back, zone of parental discretion. So I can put that after this, when I've got a clear head, I will go on to the Q&A and I'll add some answers into the Q&A in text as well. So the zone of parental discretion. So when you're in that time when you're wanting to you're wanting to step back about saying, okay, physical safety feels like it's paramount, but actually for this family, it's about enjoyment of the mealtime, and feeling that space to do that. So in the zone of parental discussion, you discuss, is this a serious risk of harm? And it's also highlighting it's not about what you would do as a parent, it's about, this family's decision. So it's hard often when we're a health worker, we often see physical health as the main thing, but actually seeing it in that broader. So if it's a serious risk of harm, that's a different thing. But if it, oh, well, it might be risky, we need to be a bit brave about that. I think it's lovely to have that question, because I think often we start to forget that we're speech and language therapists and we're becoming just swallowing therapists, and we're not. Like my mealtime, like the other studies that I've done that I'm not sharing today, I've got lots of examples from parents talking about how their child was now a young adult, and the significant impact on participation, having taught their child that they could only eat in a quiet environment because they had a strong startle reflex, and now their son can't go to most adult activities because they involve food, and he finds it too difficult. Whereas if we'd worked on it and thought about strategies around it, like maybe have the most of his calories on his own, and then the family joins, they have dessert all together when they're joking and laughing, and it's a softer, easier to eat dessert, like a mousse. So, like trying to balance those things.
Absolutely.
That honest conversation. Sorry, that was a very long answer.
No, no, I think that was an excellent answer. And I know from Susan's work, from bits that she's presented before, she draws the parallels with, if you are not enjoying the mealtime experience and you are not involved in those discussions or those activities around meal times, what happens, and she showed you kind of the length of time people were eating, is that you will eat as quickly as possible to get out of that situation early. And actually, for people, if we just consider people in a mental health setting who do not have an oropharyngeal dysphagia, they are at increased risk of choking by that alone. So that time, they cram in their mouth. There's some garden behaviours as well. They just want to get out there because it's such an unpleasant environment. So actually, when we're balancing risks, if we can involve them in discussions, if we can make the environment nicer, then they might actually take more time, and we reduce that kind of physiological risk of choking there as well.
Mm.
One of the next questions we had was around kind of the barriers to making changes. So whether that be within staffing groups, within policies, changing menus. And I know in Susan's work, she does talk about meal times is that rehabilitation potential within mental health settings. And yes, for those who are have very poor mental health at the point they are admitted, they will welcome that responsibility of the preparation of meals being taken away from them. But if we are looking towards rehabilitating people to get back to a home environment, then things like meal planning, doing the dishes afterwards, all of those things are very, very important. um, towards actually rehabilitating people and getting them back to normal. Do you see any barriers, Sally, with kind of the work that you've done in terms of whether it be infection control policies and
yeah, I think there are lots of different things there. My PhD focused on family carers. One of the barriers family carers talk about actually is school-based services. And family care even said, I'm jealous of the school staff because they have a speech therapist on site. And I used to have a speech therapist, and now they phone me and they send me, they say how they're doing. But, like that, I don't think we think about that enough. And it was interesting that it came up very much in COVID that families went, speech therapists like, wow, I really know my family. It's very hard, particularly if we have like the structural barrier of, I understand why people want term time only contracts. I'm a mum, but I also understand why term time only contracts aren't ideal for when we're trying to, link up with families. So really creative thinking needs to happen there. And I know, there's a poster. Helen has got a poster about talking about a school-based school employed team and how they're trying to tackle that. Um, I think it's also about coming down to kind of whole school food policies. So there is a project called Adapt Ed Nourish, which is at University of Hertfordshire, and they did a lovely project looking at how to adapt a whole school food approach, which is looking at food in the curriculum as well as school dinners. Special schools children with SEND with an EHCP are more likely to be entitled to free school dinners, but less likely to take them. So it's really exciting. I can see some stuff really looking at those structural barriers. But yeah, just as the same in adult learning disability literature, high staff turnover, the school mealtime assistants often being the least well paid and the least trained staff in school, and really really getting to know them and getting to know everybody in your school, like the catering staff, everyone, really encouraging that whole school approach to food and nourishment. It's not just food, it's about nourishing yourself.
absolutely, that's fantastic. Thank you. We've had a question around how can we improve kind of the consistency around mealtime guidelines and recommendations?
Oh, that's really interesting. I don't, the thing is, we don't actually, like, I was really interested in the variety. It was much more varied than I expected. Um, I'm not sure that we know that one model is better than the other. That's the main thing. I'm going to be finishing my PhD and I'm going to be staying at university. If someone wants to do a PhD at looking at um, mealtime guidance, and that's just a topic ripe for discussion. It's very different, say, to like communication passports. There is a bit of variety, but one we've agreed on a name. So I I think it really does need a proper bit of work rather than just saying because we don't know which is better. And the very small, I had an MSc student once did a lovely project in adult learning disability, and she asked the support staff in the day centres, and she asked the physios and the nurses and the multidisciplinary teams, how should we change and improve the mealtime recommendations document they had? And actually the support staff asked for completely different things than the multidisciplinary team thought they needed. So we really need this proper co-production of it. And my parents just don't use them. By the time they've got school-age children, they look at them, they glance at them, it's in them. It's so innate. They didn't really know that they had so many skills that they did. It's really tacit knowledge. So we've got to remember that these documents aren't really for families anymore. They are for the other staff. They're very useful when they've got carers and other people, but beyond that, so we've got to think about why are we spending a lot of time on them when we don't know they work? Yeah, yeah.
Absolutely.
And
Yeah.
it's a lovely PCAF NIHR award, PhD. Oh gosh, I would love to help someone. I would love to be involved in that, but it's not where I'm going to go next, I don't think.
Absolutely. I do think the wording we use around it does have different connotations. So recommendation sounds like something you should follow, but you've got a bit of flexibility that you could probably gear away from it.
And do we call it swallowing or mealtime? That has a very different connotation, doesn't it?
Brilliant. Brilliant. Um, then we've had another question, and it's really around where we've got environments um, and the difference between where meal times are seen as purely a nutritional perspective, but also encouraging other people in that environment to sit down and have meals. So, for example, in your environments, like the teachers, the support workers and things having meals there. Um, have you found that is that a model that places are using that they have support there, or is it varied?
So I think it's really varied. I go to the school food. I'd encourage people, if you ever want to do something really different, go to the school food all-party parliamentary group. So you get to go to government, which feels very fancy, but they're all there focusing on having meals together, whether it's in mainstream or special school, and they're thinking about improving the nutrition, but improving the environment too. So we know our European partners, like in France and in Sweden, people are amazing. They can have really quality food and the teachers sit with them. And things like Nourish, which is a school food matters, are working at that level and really encouraging all school staff to be engaged and for, not for the dinner time to be cut and cut and cut, actually for the dinner time to be seen as part of the learning environment. But we need to get the space right. I did a small project with some of my trainee speech therapist students, and they measured the noise level in 5 schools in the UK and in London, and all of them were breaching UK safety levels in terms of noise. So loud that the dinner staff should have been wearing ear defenders. So, there's a lot of things that we could think both about communication and about eating and drinking. It's one of those public health things, that we were talking about yesterday.
Absolutely. And I think it pulls into your point as well that you looked at, the therapists who were seeing people with autism and who were seeing people with RFID as well, and potentially that mealtime environment. And if people have mealtime differences
Mm.
or preferences, how do we support those as well? I can't imagine anything worse than sitting in a really noisy, crammed school dining hall. Yeah. Um, Then we've had some more sort of questions around sort of sharing of resources. So, for example, all the resources that people uploaded to your study, Sally, and looking at kind of different ways that we could get better at sharing kind of documentation with each other. I will say from an RCSLT perspective, if you have templates that you're willing to share, we're more than happy to have a look at them and see if they're appropriate to go up under the resources pages on the website. But what about kind of the ones that were in your study, Sally?
Hey, so at the moment, I'm not finished my PhD, and I'll have to check the ethics. But a lot of the data that I'm gathering will be open access once I've finished my PhD. But there's rules about me not sharing it until it's agreed that it's passable. I'm not there yet. But if you sign up, then I will be able to do those things. And I think either through RCSLT or it's in my head, the families my prototype is about a lot of it was about resources to help people just to be quicker in those things so they can spend more quality time with families and other carers.
That's great. Thank you so much. I think we've all learned so much around meal times and expanding our role there. Thank you.